Well, good morning to everyone that's here with us today. I'm Elise Suna. I'm the Education Director with the Melissa Institute for Violence Prevention and Treatment. And today we're going to be having Dr. Sherry Hamby joining us, and you'll hear a little bit more about her from Dr. Alderondo in a minute for our innovations in violence prevention treatment. But we're really excited to host this. We know starting the summer off with a really important topic after a really challenging year, and continues to be a challenging time. So, and really looking at the resilience that many face during this. So I'm very, very personally excited to see this presentation as well. And without further ado, I'm thrilled to pass it over to our Executive Director, Dr. Etione Alderondo.
Good morning and welcome all. It's a pleasure to have you with us today again. It's an immense pleasure for me to have an old friend and distinguished scholar, Sherry Hamby, presenting and sharing her knowledge and wisdom with us about on issues of resilience and trauma. And if there are two things that we have become uninvited experts during the past year, it's in both trauma and resilience. You know, we've been exposed to it. Many of us have been able to get through it in different ways. A lot of us have suffered the loss of others who were not able to do that. But regardless of our position in that spectrum of success or not, in dealing with the pandemic, we have actually become a lot more sophisticated in our experience of what this really means, as well as in what prevention really is about, what the work of prevention and why it matters. So we're very fortunate to have here with us Dr. Sherry Hamby speaking with us. Sherry is a research professor of psychology at the University of the South and the director of the Life Path Research Center. She's also the co-founder and co-chair of the Resilience Con. Sherry is an internationally recognized authority on victimization and trauma, who's best known for her work in violence measurement, polyvictimizations, and resilience. She's an influential researcher and has been ranked in the top 1% among more than 6 million researchers in 22 disciplines, based on citations to her work. Needless to say, we're extraordinarily happy to have you. She's also one of the, I think the newest member, one of the newest members of our scientific advisory board. And we're really, really honored to have you with us today. Sherry, we will be giving information to all of you also about how to access a new book that Sherry just published out, I believe by the American Psychological Association. There will be a link that you have access to. They were kind enough to make it available, especially for you guys who are watching today. So you'll be hearing more about that soon. And Sherry, I'll leave it to you.
Thank you, Etione, and also thank you to Elise and Amanda. I'm really excited to be here, and I appreciate very much that kind introduction. We were just talking about how stressful the pandemic has been, and so I do just want to start today trying to create a little space that's hopefully this will be a little bit of a break in your routine. And so maybe just take a moment to take a deep breath, maybe roll your shoulders back, try to relax your jaw, or, the thing I often find myself doing is like really pressing my tongue into the roof of my mouth, which is, kind of a marker of stress for a lot of people. And so if your tongue is up there, try to let go and relax. And this is just hopefully going to be a space where we can all talk about some meaningful aspects of our work, and hopefully you will get something out of this, but also hope it will create like I said, a little space from your daily routine. So what I want to talk about today is resilience after trauma. And just to put it in a little bit of a context, Etione and I were both just chatting before we started the webinar about being postdocs back in the 1990s. And, in the 20th century, people were, of course, aware that some people were resilient, but I like to think that they talked about it as if resilient people were unicorns, just, like these amazing, remarkable people, rare. Maybe they didn't, some people weren't even sure if they really existed or not. So I think of that as being like a unicorn. But it turns out that, that really resilient people are like squirrels. We're everywhere, almost everyone has experienced trauma. And and there's all kinds of people who, despite, in some cases, really extensive trauma burdens. I mean, I have a trauma history. Probably most of us on the webinar today have a trauma history, but that there is still, really accessible, viable paths to good lives and to thriving, despite sometimes even really high doses of trauma. And, and that's really like the main thing I want to talk about today. So we are going to start off a little bit with trying to understand the pervasiveness of trauma, because even though that can be kind of a grim message in some ways, I think that's an essential starting point, is to reckon with what the true burden really is. And then how understanding that burden just opens up all these unexpected insights about resilience and what it takes to thrive after adversity. And then in the final section of my talk, I'm going to talk about some what I hope are like pretty concrete and accessible ways that you can promote resilience, either in your own lives or in your work and in different settings that you might be working in. So first, as I mentioned, we've been working on many of these issues for many decades now. In the 20th century, when I got trained in psychology, I'm a clinical psychologist by training, people, of course, knew that violence and trauma were bad for you. And that was really the second half of the 20th century, was when we really first started investing serious public resources into trying to prevent and heal trauma. But a lot of these problems, the picture I've got from one from Kelly Foster and one of our assistants in the Family Research Lab at New Hampshire, with child victimization, but it's true for adult victimization too, that a lot of these efforts came up in very disciplinary silos. And when you think about it, I mean, they don't even really make sense that we have like separate institutions to work on child abuse versus domestic violence, or, or sexual abuse of children is dealt almost completely differently from sexual assault and rape of older adolescents or young adults or older adults. But they've, for lots of different historical reasons, they fractured into these different silos. One of the problems with that approach is that even though back in the 70s and 80s, when some of the big first nationally representative studies were done, people were shocked by numbers. For example, in Murray Strauss and Rich Gellis and Suzanne Steinmetz study, that 1 in 10 couples had experienced physical violence. It was still this narrow perception of violence, and it was kind of assumed that those other 90% of people were not victims at all. I mean, that's what we typically would call them, as non-victims. But around the turn of the century, that started to shift in really important and revolutionary ways that I think 20 years later, we're only now starting to really reckon with how fundamentally this has shifted our understanding of trauma, and along with that, resilience. And probably the first big marker of that was Vince Filitti's and Bob Anda's Adverse Childhood Experiences surveys, or Aces, as most of you are probably familiar with that term. And there were some things that were really remarkable about that study. It was this large, mature sample. The average age was in their mid-50s, and it included people in their 90s. And it was also a really privileged sample. It was mostly white, mostly college educated, and every single person in it had health insurance because they collected the data at a health maintenance organization in California. So But he had gotten interested, Vince Felitti, in his clinical practice with stories about how childhood experiences, even in this older sample, were still impacting these people. And what he found when he did this large study, I think the first one had about 9,000 people in it, was that childhood adversity was still strongly associated with health decades later. Now, of course, we already knew that about individual types of, physical child abuse, or even by then, perhaps, bullying or community violence or things like that. But what was remarkable about his work was a couple of things. I mean, one, that he looked at a lot of physical health consequences and not just psychological ones like PTSD and depression. And so one of the remarkable things is that he found these incredibly strong relationships with conditions like heart disease, cancer, chronic respiratory ailments. And now these days, this has been replicated in hundreds of studies and more than 40 different health conditions, including all of the top leading causes of morbidity and mortality in the United States. And that the second, and perhaps, I mean, I guess I would say that in terms of the physical consequences, I think that is what has really helped put it on the map in a lot of policy areas. So for example, in my home state of Tennessee, there is an Aces initiative now that the state government has gotten really heavily invested in. And I do think it's because a lot of policymakers take, of course, there really aren't hard and true lines between these things, but they take, like physical diseases more serious than psychological ones. But I think that the most important thing about his study was the impact of dose. And so what he did was, instead of just saying you were either abused or you weren't, like most of the studies at the time still did, is that he actually counted up he and his colleagues, different types of childhood adversity, and included different types of child maltreatment, also things like growing up in a home with parents who are addicted to substances or had serious mental health problems themselves or things like that. And so there were like 17 different questions of different types of mostly family-centered, serious household problems, abuse or other problems. And what they found was that there was this huge dose response effect. So if you had one of those problems, you were worse than 0, 2 was worse than 1, 3 was worse than 2. This particular graph is just sort of an idealized version of it. And in particular, there was often a big jump when you got to 4 or more of these adversities. And when you think about it, it's really remarkable that in this older sample that, often we're talking about events that were more than half a century previously in these people's early childhoods, and that you could still see the burden that they were carrying on so many different medical and psychological conditions. Now, around that same time, 1998 was also the year that David Finkelhor, Heather Turner, Dick Ormrod, and I started what would eventually become the National Survey of Children's Exposure to Violence, which were a series of nationally representative studies that happened in the aughts and early 2010s. And we found very similar results focusing on much younger samples. And so our work was with youth from age 1 month to 17 years old. And we also came up with something we called the Juvenile Victimization Questionnaire that captured trauma, not just in this yes or no way about some particular type, but in terms of dose. So how many different types of victimizations had you experienced? Caregiver maltreatment, community crime, peer victimization, sexual offenses, and also exposures to indirect events or community or societal level problems like terrorism or mass shootings. And we found the same dose response relationship. So again, that 1 was worse than 2, was 0, and 2 was worse than 1. Unlike that previous slide, which was this sort of idealized figure kind of aggregating it, this is our actual data from our first NatSCEV study. And it's just really remarkable how consistent and predictable this is for raw data. So what we have learned from that is that it's super important not just to focus on one particular type of victimization, so, bullying in the school or something like that, but to really take a comprehensive and holistic assessment of people's lifetime cumulative burden of trauma. So yes, like the ACEs studies, we do need to ask about child maltreatment and other types of problems in the home, but we also need to ask about bullying, other types of peer victimization. We need to think about a lifespan approach and understanding the effect of community violence, workplace harassment, police brutality, and then also include, sexual offenses of different kinds. And even beyond that, we are finally starting to get better at looking at the effects of different forms of oppression and victimization, so racial trauma, homophobia, transphobia, sexism, etc., and historical trauma, which refers to many of the same things, but that is usually like the multi-generational effects of systemic oppression and victimization. So some of the famous examples of that are the way that the children of Holocaust survivors, often carry the burdens of those experiences too, or how, what's in the news now today with the horrible tragedy of discovering the bodies of those 215 children at near a Canadian residential school for Indigenous or First Nations peoples. Those kinds of traumas, the impact of those can really last for multiple generations. And then even beyond that, one of the things that we have learned from NADSCAV, and we've replicated this in 3 different national samples as well as many other studies, is that, is that a lot of things that we used to think of as like lesser types of exposure really add to our lifetime burden in similar ways as what you might think of as, kind of like classic topic areas in victimization. So for example, we're finally starting to realize that bullying and peer victimization can have, it's not just, kids being kids, but that can have lifelong impacts too. And we've also found in our work that even witnessing or seeing the aftermath or otherwise indirectly getting exposed to trauma has a similar impact on our bodies as being a direct victim. For example, probably one of the best known example is children exposed to domestic violence, but also, even for those of us who are on this webinar today, the vicarious trauma that we can experience from working with victims of violence is something that adds to our dose of trauma exposure, and that we need to think about ways of balancing and managing in our work. I often ask people to think about it. I'm a mother of 2. I've got 2 kids who will both be in college next year. And, and as a parent, I think about, what the impact on me would be like if I, got mugged or assaulted versus my children. And I think that it would be at least as hard on me, if not harder, to know that my children had been hurt than that I had been hurt. And so, I think we have to be careful not to minimize those kinds of indirect traumas as well. And then, of course, before the pandemic, I, sometimes would get pushback from people that the burden of trauma was that high, or some people would like to think that through some combination of privilege and virtue that they would be able to completely escape trauma in their lives. But now I don't get as much pushback on that, because I think the pandemic has shown us that, that everyone is going to get exposed to trauma sooner or later, and that, that those kinds of exposures, that some of them, we can certainly minimize them. I mean, that's what prevention is all about, and I'm a big fan of prevention, but we don't have total control over it. And so we have to be prepared that these are, bad things are going to eventually happen to most of us, and that we have to be prepared to deal with these kinds of ups and downs. And of course, as Etione mentioned at the introduction, that many of us have experienced loss of loved ones, or those of us who are direct frontline providers, you know, have been experiencing a lot of anxiety and stress from you know, being exposed to it. But even if you were relatively insulated from the pandemic, it certainly has turned all of our lives upside down. So the conclusion of all of that, and I'll show you some data in a minute, but the big take-home message from all of that is that most people's trauma dose is not zero. And, you know, in a lot of professional settings, we're kind of trained to act like we have our lives like completely put together. But in fact, most of our trauma doses, you know, we all have trauma dose. And I think if we brought that recognition more centrally to our work, that we could really make a big difference in how we are relating to many of our clients and students and other people that we work with. So I am a researcher by now, so I am going to show you just a little bit of data about this. So this is from a recent study that I did in my rural community in southeastern Tennessee. This is a quite young sample. Their average age is only 16. They were youth ages 10 to 21. And even before the pandemic, almost 9 out of 10 of them reported at least one victimization experience on the Juvenile Victimization Questionnaire. And if you included other types of adversity, like the loss of a loved one, then you got up to 99.5%, you know, even by an average within this young sample. From the same region with somewhat larger sample that included adults up to age 45, we got pretty similar numbers. Almost 9 in 10 reporting at least one form of victimization, and over 98% reporting at least one form of victimization or adversity, such as the loss of a loved one. That kind of data is not unique to the United States. One of the questions that I get a lot is that, you know, if we had a better social welfare net, or if we were, you know, had more social justice in our country, you know, would these kinds of numbers really shift? And of course, those kinds of things are essential parts of the solution, but we are still a long way from figuring out how to eliminate trauma in any society. And so most of these are studies using either the JVQ or the Aces Questionnaire. And you can see that these adversities are pervasive around the world. So even in places with really substantial social safety nets, the victimization rate, it is somewhat lower than it is in those samples, but it's still really high. I mean, it's still most people, you know, running most of these around, you know, 75 to 85%. And these are also mostly adolescent samples. So, you know, even in places with really substantial social safety nets like Canada or Spain or Sweden, you still see really high levels of trauma exposure by the time people reach adulthood. Now, why dose matters. And so one of the things that this has really done is transform the work that's being done on mechanisms. And so it's one of the reasons why it's much more important to think about dose than it is to think about even, you know, any one particular type of victimization. And I know that that is a shift for a lot of people, is because, you know, the effects of trauma on our body are physiological. I like Bessel van der Kolk's phrase, the body keeps the score, you know, and this is, you know, I just think is so important. I mean, I did my dissertation on domestic violence. You know, what didn't include other types of violence. You know, when I went to the University of New Hampshire, as Etienne was talking about, there they've studied both domestic violence and child abuse. And at that time in the 90s, that was kind of a revolutionary thing to even think about family violence as a type of a whole. But you know, even if you were trained, I mean, what I hope you will take away from you today, because I know that if you're trained in one particular type of violence, or if you're at an institution that works with survivors of a particular type of violence, then it can be hard to make this mental shift. But the thing is that we don't have different systems in our body for responding to bullying versus child abuse versus sexual assault. We really only have like one stress response system. And, and of course there are different levels and, and it's complicated, but there's a lot more similarities and differences than there are in the way that we respond to any kind of stress. And so what happens with trauma dose is we get exposed to multiple different types of stressors, is that affects the wear and tear on the body, or the formal medical term for that is allostatic load, which is usually assessed by different markers of chronic stress. So cortisol reactivity, inflammation, things like that. And what happens, especially if these stressors or adversities happen during childhood, is that it overworks our physiology if we're experiencing a lot of different stressful situations, and it affects our hormones, which is our neuroendocrine system, our immune systems, our metabolic systems, our stress response systems. If these happen when the child is still developing, they can have long-term impacts, for example, on what amount of stress will trigger like a cortisol response in your body, and setting different thresholds and things like that, which can have, that goes back to the Aces study with Felitti about why, the 92-year-old person, probably their parents are deceased. They're certainly not being taken care of by their parents anymore. But yet, even though those people no longer have that kind of control or role in their lives, the impact of that abuse can still be seen so many decades later. And we're starting to understand, I think one of the most exciting frontiers of a lot of research is that these can create these vicious cycles with other types of things that we've been researching for a long time. So for example, there's some studies that are coming out now that shows that how allostatic load can lead to depression. Depression can lead to self-medication with substances, or alcohol or illegal drugs. These things are not good for your body either. So then they're aggravating inflammation and, maybe causing free radicals and things like that. Then that can also, so that is all adding back up to increasing your allostatic load again, which is going to make your depressive symptoms work. And then you start to throw in how this is all starting to affect your interpersonal networks, that your need for recovery and thriving. And you can see how these things can really end up in these vicious cycles that can be very hard to escape from. And that Hamby et al. References to a review of all of that came out in American Psychologist earlier this year. So that's all kind of a bummer, right? That's a pretty grim story. You get told that a lot, that's a pretty dark story. And I totally get that. But I think that it is such an important story, because once we understand that broader, comprehensive lifespan perspective on trauma, it turns out that totally transforms what we know about resilience and how we can think about resilience, and how we can stop, kind of putting band-aids on these one little individual problems at a time here and there, and also take a more comprehensive lifespan approach to helping people thrive. And I really think that this is going to, be where the next 10 years of research are going to be, that's just going to transform the way that we think about helping people who have been traumatized. So the first thing to know about that, and one that frankly was surprising to me, or I came to, rather late in the game myself, is that good stuff is more, surprising to me, I guess, as a researcher. This is the part where I'm talking about where we need to like integrate our own personal trajectories. This is, was an important part of my personal path to overcoming my own traumatic experiences and putting together a good life where, but, it was something that I had not made that connection with the science and the research. But it turns out, and these particular pie charts are from that same sample of youth ages 10 to 21 that I showed you earlier, but you can find this in lots of different studies and lots of different samples. It's easy to replicate, is that even though, you know, adversity, so victimization and things like that are bad for you. So I spent really about the first 20 years of my career mostly focusing on this yellow piece of the pie here. I mean, it's a pretty good sized chunk of that pie. You know, it's, you know, you can find it over and over and over again. It's the most easy to replicate finding. I don't know if I've ever seen a paper that couldn't find this. So you certainly can spend your career on that yellow part of the pie. But it turns out that that yellow part of the pie, of course, is only one piece of the pie. And if you start measuring strengths, if you start measuring the psychosocial assets and resources that people have, so I want to really emphasize like upfront and early, because a lot of times when people talk about resilience, we think we mean something like grit or, you know, or emotional fortitude or something like that. And you know, while those things are good, that is not what people mean by resilience. Increasingly, is that we're thinking about it from a more social ecological point of view, which I'm going to get into more in a minute. So these strengths are not just your own individual strengths, not just your own capacity for emotion regulation or impulse control or whatever, but also, you know, their interpersonal strengths, your resources from your families, from your friends, from your communities, from your cultures. And if you add those all up, which we're still figuring out in a little bit less advanced way than we are with trauma, what the best way to measure all that is. But still, even with what we know now, we can account for a bigger piece of the pie, but in terms of how people are functioning with trauma symptoms, if we focus on strengths. If you move to some more positive indicator of how people are doing, so measuring their overall psychological well-being and not just their symptoms, well, then the adversities is an even smaller piece of the pie. It's still a piece of the pie that's statistically significant that you can find over and over again. But the strengths is this really big piece of the pie. And so this, I think, starts to show us how we can help people get to a state of thriving and well-being and overcoming, even if they have high doses of victimization, as in this sample, which is a really highly victimized sample from mostly low-income areas in the Appalachian region. Now, the exciting piece of work that's happening that I just think is going to transform, you know, work on resilience and how we think about therapy and positive psychology and a whole host of things, is that this dose concept is starting to get brought into the area of resilience and positive things that are going, and strengths and positive things that are going on in our lives. And there's a couple of different formulations that are coming out of the work that's happened so far. One of the biggest, one of the ones is something that's called positive childhood experiences, or it goes by some other names, which I think I have on the next slide too. But this is one that's been used quite a few times. And this is basically a very intentional effort to provide a counter to adverse childhood experiences. So trying again to think about those early childhood years and what kinds of things help people. So, community traditions, feeling support from family, school belongingness. Probably my own one that I think for people who have got classic ACE style family problems is number 6 here, having at least 2 non-parent adults who took genuine interest in them. And they count these up just the same way that people count ACEs or victimization types on the Juvenile Victimization Questionnaire on the JVQ, is that they just give you a score from 0 to 7. These also appear to function in a dose response relationship to outcome, so that people who answer 7 are going to be doing better than 6 versus 5, et cetera, et cetera. You might also see this coming up. They haven't really settled on like D name, the way that ACEs has kind of become like D name for that. So you'll see research under like beneficent childhood experiences or positive and compensatory experiences, which they're calling PACEs, which of course nicely rhymes with ACEs. And that, I mean, there are good things about that, but my team has come up with a somewhat different concept of dose. And, you know, and of course we think ours is better, right? So if you want to know why positive childhood experiences is better, at Tiona, you'll have to invite those folks to come in and give a webinar for you. But our conception of dose is a little bit different. We have 3 domains in our resilience portfolio model. Regulation, so that is, you know, like emotional and behavioral regulation, you know, impulse control, things like that. Meaning making, which I think is probably the most important and one that has been really, I mean, there's a whole literature on meaning making, a quite large literature on meaning making, but it has surprisingly not really been very well integrated into the literature on victimization and trauma. And then, as I mentioned earlier, interpersonal strengths, which are where we bring in the rest of the social ecology with resources from families and communities, et cetera. There are, I think, a couple of strengths of our model that are really important. Like if I go back, and I don't do direct services anymore, but if I still try to put my clinical hat on sometimes. And so one of the things we've tried to do with this model is really focus on malleable strengths, you know, things that can still be changed. And you know, and include the full social ecology. So let me show you what I mean by going back and looking at the PCE index. So I mean, these things are nice. I mean, I have to tell you that, you know, again, as somebody who grew up in a family, I mean, both my parents were alcoholics and depressed and, you know, really struggled a lot. I mean, I would not be able to say yes to all 7 of these things. And you know, there's nothing that I can do about that now, right? I'm 57 years old, and that some of these things that weren't true when I was a kid, they're just not going to ever be true. I mean, right? I mean, that's historical fact about me. Now, if you wanted to use this to guide intervention, you know, I think some of these things you could work on, like I'm a big fan of mentoring programs, like Big Brother, Big Sister type of stuff. And so I think if you worked with young children that you could try to beef up number 6 here, or maybe you could try to work on school climate was like number 4. But some of these things are really, you know, kind of outside the control of people. And if you're even working with older adolescents or young adults, I mean, some of these things, you know, that the ship will have sailed on that. And so I don't think that they are as useful for that. And, you know, so that's what I mean by like, they're not malleable. They're sort of historical facts for people in a lot of different settings. And the other thing about them, oh, I knew there's one more point I wanted to make. The other thing about them is that also that all of these things are things that are being offered to these kids. And I think that even for, I mean, you know, maybe for toddlers, no, but even if you're working with, you know, like older elementary or middle school children, I think the limitation of this positive childhood experiences model and the similar versions of it is that there's too much focused on what adults are offering to them, you know, except for the, you know, number 5 here with peers, you know, most of these are really focused on what adults give people. And I think that that doesn't give enough consideration to the agency that kids have, even at fairly young ages, to help impact their own environment and well-being. So we've done several studies with the polystrengths model now, which is what we call the kind of it's like equivalent to like the ACE score, like a sum of how many strengths that somebody has. And we have studied now 35 different strengths, trying to draw on ones from these 3 different domains. So the first column here is our regulatory domain, the second is meaning making, and the last one is the interpersonal domain. And originally what I thought was that we were going to have a hard time narrowing it down, because there are people, there are teams of researchers or even entire silos. So the resilience and positive psychology fields, they've gotten really siloed too. So there are tons of people who focus on things like attachment or they focus on research like generativity or social support or emotion regulation, and what happens with the problem with that research is really the exact same problem that I was talking about at the beginning of the webinar with the early research on victimization and trauma, is that if you're a social support researcher, then the only positive strength that you might include in any of your research is social support, or ditto if you're interested in emotion regulation or attachment or whatever it is. And so the problem is that they've lost a couple of things with that. Is that one, that they've lost the ability to measure dose. So they have the exact same problem that folks who only, like in my dissertation, I only measured domestic violence and I didn't measure anything else. And so I can't really capture dose very well with that. And so the same problem on the strength side is that you can't really capture somebody's portfolio of strengths if you're only measuring one or even two strengths in your work. And then the other problem with that is that they're not really putting what they think is the winning one on this list to any kind of test. So really, again, putting my clinical hat on, what is most important to know is like which of these strengths is going to give you the most bang for your buck. So especially for folks who are working in any kind of clinical or human or social services setting or schools or anything like that, you're going to have limited time and resources, right? We all have limited time and resources. And so it would be incredibly helpful for you to know, well, should I focus on emotion regulation or should I focus on social support? I'm only going to get, 4 weeks to run a program, or 90 minutes to run a program, or even if it's, 26 sessions of individual psychotherapy, which is a lot in a lot of settings, you still want to know, like, what's the best way to spend your time. And the only way that you can figure that kind of thing out is to put these up to like head-to-head comparisons of each other and find out which is most important. And because there are so many people, including some of my close colleagues, who are so invested in individual ones of these, I thought this was going to be this incredibly difficult job to do. We were hoping to take, these 35 and, others that still could be tested and wean them down to maybe 10 or 12. But in fact, that is not what has turned out at all. And in fact, we have had a few of these that are much bigger winners than any of the others. And so I'm going to start with meaning making, because it is turning out that meaning making is explaining more of the variance and how people are doing in terms of thriving despite really high burdens of trauma than any of these others. And even within meaning making, like far and away, our big winner is, a sense of purpose, or whether people feel like they have some, kind of important meaning to their life. And then next to that, would probably be mattering, or feeling like you really matter to important other people. I'm going to spend a moment talking about this because I think it's such an important idea that needs to be folded much more into our services. So there's lots of different ways that you can develop meaning, and short of joining a cult, most of them are probably pretty good paths to developing a sense of purpose. So for example, dedication to a cause. I mean, most of my work is developed around, my commitment to the effort to try to reduce the burden of trauma in society. It's what gets me, out of bed this morning. It's why I'm here on a Friday morning in the summer. It's probably why many of you are here, on a Friday morning in the summer, listening to this webinar, is that you're dedicated to a cause. Other things like commitment to a role. I've already spoken about being a parent. I'm also a teacher. Like, these kinds of things are hugely important to me, and really they motivate me to keep going even when I don't feel like keep going. For many people, religion and spirituality serves an important role. For young people, we have found, that being future oriented and thinking about being motivated to want to go to college or, learn a trade or develop, their athletic prowess or their artistic skills, that those kinds of things are really important. Or, adhering to a code of values or ethics, that these are some of the classic sources of meaning making. And really, we should be orienting a lot more of our services towards helping our clients figure out what their sources of meaning making are. Instead, I think what happens all too often in a lot of services is that we're providing, our own meaning making, but we're not providing folks with like a very clear pathway out of the helpee role. For the regulatory domain, emotion regulation, endurance, those were ones that came out big. But one of the ones that we found, and this was something that we really discovered from talking to people in qualitative interviews and focus groups, was this idea of being able to regulate positive affect. So almost all of the work that has been done on emotion regulation has focused on regulating negative types of affect. So there's a big literature on anger management, for example, that many of you are probably familiar with. There's also a big literature. Most of the measures in the field essentially, they call themselves emotion regulation, but they actually only talk about, one kind of emotion, which is being distressed or upset. And those are certainly important, but a lot of times if you're managing your anger or you're managing your sadness, then you're just kind of like not angry or not sad. And what a lot of the folks in our focus groups and qualitative interviews were telling us is that what was important was this capacity to be able to cheer themselves up again. And, and not just, it's like to really put something behind them and be able to enjoy other things and laugh and get back into a good mood. And so that's what we're calling, the ability to recover positive affect. And I think that is a really important idea that has a lot of potential. And so, it's just the idea that if you get a flat tire on your, even for little daily hassles, you get a flat tire on your way to the office, like for, when we go to offices again, is that gonna ruin your morning? Is that gonna ruin your day? Is that gonna ruin your week? Are you still gonna be grumbling about it like a month from now? Like how long does it take you to be able to cheer yourself back up after something bad happens? And in the interpersonal domain, the one that we have had the most success with is social support received. Well, I will say in general, that we've actually really struggled with this interpersonal domain when we start looking at it from a more comprehensive and multivariate approach than we expected. And one of the reasons for that is that I think a lot of the measures out there don't know it because they haven't been taking this, multivariate approach. So if you only measure social support, then social support basically has to be like your only indicator of like the whole resilience portfolio. So you'll find, bivariate positive relationships. Every single one of these 35 measures at the looked at alone at just the bivariate or just simple correlations or things like that, they're all significant. But when you throw them into these head-to-head comparisons, these are the ones that really come out as still being important even after all the other ones are taken into consideration. So for example, on social support, to make this a little more concrete, one of the things that we found is that we used some early measures that just basically measured social support in terms of like a lot or a little. And one of the things we found is that the adolescent males who were reporting a lot of social support were also reporting the highest levels of delinquency. And so then we started wondering, well, like, what are they getting socially supported for? And you can't tell that on a lot of the measures that are out there. It just means that you've got a lot. So if it's going to look the same on those measures, whether you're getting social support for shoplifting or sneaking into movie theaters or things like that, versus, the kinds of things that when, us, health professionals think about social support, like what we mean by that. So we've had to rewrite a lot of those measures. One of the other ones that we found really had this double-edged sword was, some of the, family-focused ones. And that is the kind of thing that's really personally important to me. Like, I'm the one in the family that does a lot of work around holidays and maintaining family traditions and stuff like that. And, that is a real source of joy to my life. But what we were finding in these multivariate analyses is that you can also kind of see like the burden of that too. I mean, there's a lot of talk these days in the media about sort of the mental labor or emotional burden of that kind of stuff. And so that's what I mean by a lot of these they were more complicated than just the meaning making and regulatory ones. And so we're still trying to figure that out, although we still think the social ecology is hugely important. So in terms of like the next frontier, I really, like I said, I think this is going to transform the way that we think about prevention and intervention. As Etione mentioned at the top of in the introduction, Vicki Banyard and I have a new book coming out from APA called Strengths-Based Prevention, and we have a code that you can use to get a 25% discount on that. I really think this is what's going to be the new direction. And what my work is really going to be focused on for the next 10 years is trying to figure out, what are the key combinations and how we can translate those to practice. And I do think one of the ways that we need to do that is to get more of the untapped wisdom of all the squirrels that are out there and to bring that knowledge more into our work, including our own personal knowledge. But that is where I want to shift to next, and for the last section of the webinar. So there are a lot of evidence-based interventions that promote strengths and support thriving. And I think the key thing to understand about most of these interventions that I'm going to talk about today is that they're not actually focused around coping with the victimization or trauma or processing the trauma or things like that, but that they're focused on those pies I showed you at the beginning of like trying to just directly promote thriving and well-being and reducing symptoms. And, so if you're doing yoga, you're not doing yoga about your trauma history, right? You're just doing yoga, but yoga is a great way to just generally feel better. And a lot of these things, mindfulness, exercise, forest bathing, a lot of these kinds of things work in the same way. There's been a ton of research on this, but there was a really big meta-analysis that just came out a few weeks ago that showed, and with an even larger and more definitive number of randomized controlled trials, that a lot of these things work at least as well, if not better, as any kind of conventional psychotherapy or psychopharmacology that's out there. Mindfulness actually one that was bigger. It was the number one winner in that. It was also came out really well in a meta-analysis a student of mine and I did last year. Narrative, exercise, those are probably the ones that have the most data to support them as being, really, really powerful tools for helping people. And the therapy that came out the best in this big meta-analysis that was just published was ACT, acceptance and commitment therapy, which is Steve Hayes' model. And and his model, like a lot of the newer therapies that are emerging in the last maybe 20-25 years, I would say, are mindfulness-based therapy. So there's acceptance and commitment therapy, there's mindfulness-based stress reduction, there's things even like dialectical behavior therapy as a pretty big mindfulness component. And so I think that's really where the direction is going to be. That is not what I was taught how to do therapy at all. I went to grad school in an era that was either pretty straight CBT or even had a lot of teachers that still practice mostly psychoanalytically informed psychotherapy. And so the big difference between like cognitive behavioral therapy, so a lot of classic cognitive behavioral therapy is still focused on taking away bad things. And it also is often focused on this very, analytical and deconstructive way of looking at a person's problems or their lives. And so, for example, cognitive restructuring would be a terrific marker of that. So most of that is really focused on, like the wrong ways you're thinking, or using black and white thinking, or you're shooting all over yourself or whatever, and so it's trying to remove that bad stuff. And often a lot of times it's focused very much around your victimization or your trauma, instead of trying to, build thriving directly by these kinds of things. And I really think this is where services need to shift. And the great thing about it is that these things are much more accessible, especially in the really rural areas where I live, than a lot of traditional psychotherapy or even psychopharmacology, because aside from, going to your GP to get an antidepressant, there's not very much in terms of psychiatry services in the area where I live either. So I'm just going to try to elaborate a little bit in just a few more minutes on what this could look like in practice. And so the first one I want to take up is narratives. So I'm a huge fan of narrative interventions, and I just want to tell you the story about one of the first narrative studies was by James Pennebaker back in the 90s. And he brought his students at his university, he brought the incoming freshman class during freshman orientation, and he gave them a prompt to write about a traumatic event in their lives for just 20 minutes a day, spread over 3 days. So the total intervention was only 60 minutes long. And in the control group, they wrote about study skills and how they were going to stay on top of their work for the same amount of time, which I will just note that that's often what this control group is in these studies, because that never has any impact on anybody. And for those of you who are at institutions where they offer that a lot, it is not really an evidence-based practice. But what they found at the end of the semester is not only did the students who wrote about a traumatic event also report greater psychological health and well-being on a lot of different self-report indicators, but he also went and got their records from the student health center on campus and found that they also had gone to the health center for fewer numbers of colds and flus and other kinds of infectious diseases like that. So if you were going to get regular like insulin for diabetes or whatever, it didn't include stuff like that, but included things that were really kind of signs of stress and immune system functioning. And that was a really remarkable result, but it's again something that's been replicated a whole bunch of times. The positive psychologist Laura King wondered if you even needed like a whole 60 minutes. And so she did with her grad student a similar study where they only wrote for 2 minutes a day for 3 days. So a 6-minute total intervention. And they still found weeks later, like improved psychological functioning of those students who, and that was not on trauma, that was just writing about something meaningful that was important to them. So people think that narrative works on a bunch of different ways, like on narrative coherence. It's really important that we, be able to put our past into some sense of perspective, and that we can acknowledge what happened to us in terms of victimization or trauma without letting it come to define us, or that we can start to understand, the post-traumatic growth. I mean, obviously, as I've shown you from all that work on trauma dose, it's better if those things do not happen. But if they do happen, that doesn't mean that, much like with the pandemic, right? Like we all really wish the pandemic didn't happen. And if I could, wave my magic wand and make it go away, I definitely would do that. But you've still seen lots and lots of discussion in the news and probably among your friends and families and colleagues about things that, unexpected silver linings that came out of the pandemic was maybe spending more time with your family, or not having to make a commute, or whatever it was, and those would be examples of trying to find, post-traumatic growth experiences. And even though we still acknowledge that the pandemic is a bad thing, it can help us put it in perspective and integrate it into our lives to understand like what we also learn from the experience. Narrative also helps with your sense of purpose. emotion regulation, and a bunch of people have been able to replicate Pennebaker's original findings that it supports the immune system as well. Personally, I like strengths-based narratives. I don't think you should try to tell people what to write about, and that I think if you create a space to just write about something important and meaningful to them, that most people will take that opportunity to process the traumatic experiences. The other great thing about strengths-based narratives is that you can use them in a lot of settings where you don't know what the trauma history is of everybody in the room. So probably like the #1 example of that would be a school setting. So you don't have to assume, and even though we know from our other data that probably most of those kids do have a trauma history, you don't have to assume that or force them to talk about it in a setting where, you know, that might be difficult to manage. You know, but there would be other kinds of settings like that too, you know, workplaces or military bases or things like that, where you may not want to assume that everybody has a victimization history. You know, I've just got some prompts here. You know, some of the ones that I like. I'm actually working on a project now with one of my students who I think is on the webinar, Sergio Rodriguez, who we're trying to actually look at different studies and figure out whether or not the nature of the prompt makes a difference in terms of the level of impact. But before we get that done, this is the recommendation is for things like that I'm going with. Another one that I just want to mention that I think is like so accessible and really, you know, can be integrated into so many different services is exercise. It's been called like the first true real miracle cure. And, you know, this is another intervention, if you will, that alleviates depression and anxiety just as well as psychotherapy and psychopharmacology. You know, I think the big take-home message from all of this work that's coming out on mindfulness and exercise and narrative and things like that is not that psychotherapy doesn't work. It's just that it doesn't, you know, classic psychotherapy like the cognitive restructuring or the, you know, insight oriented analyses of your unconscious conflicts. I mean, you know, not that I you know, I love to do that. You know, my, you know, poor kids, my husband's a psychologist too. You know, we spend plenty of time analyzing things in my household. But, you know, it doesn't work any better than a lot of these other things that are a lot cheaper and easier to access, and you know, and can be done, you know, almost anywhere by anybody without necessarily having licensed professionals. And certainly compared to medication, it doesn't have, you know, the risk of side effects. So I know it's easy to say, and you've probably been told this by your doctor, you know, like, oh, it's good to go out, more exercise or whatever. You see that all the way. So what I've tried to do here is think about some ways that you could incorporate physical activity into a lot of settings. So, you know, include an evaluation of regular physical activity in your intakes and assessments. I mean, when you think about it, you know, whenever we have a person of any age, a child or an adult or a family, you know, we come in and we take these psychosocial histories, you know, if we, you know, in non-emergency settings, at least, you know, trying to get a sense of where they are. And, you know, because it is such an important element for both their psychological and physical health, I really think it's remarkable that we don't more systematically assess for what kinds of exercise that people are getting. You can create paths or labyrinths on the grounds of the facilities where you work. In the community where I live, I think probably one of the things that has transformed the community the most in the last 10 years has been the creation of something called the Mountain Goat Trail, which has been developed by this nonprofit led by my friend Patrick Dean. And it just, they built this walking, running, strollering trail, paved trail, most of which kind of goes not too far from the main road through town. So, you know, I do live in a rural area. I mean, there's tons of trails and things around, but a lot of them are not that easy to access. A lot of them are start in around the campus community, which, you know, is great if you're a student or faculty member, but, you know, can have obstacles for people feeling comfortable being there if you're not. You know, you can lots of places, you know, I mean, it's made it within walking distance of so many houses in town. It's, you know, and it's paved unlike most of the other trails around here. So it's great for wheelchairs and strollers. It's really accessible. And it has done, I think, a tremendous amount for promoting all kinds of exercise from all kinds of people. Or another initiative that the state of Tennessee did a few years ago that I think has really been great for the community is that they started paying to put little circular paths around the playgrounds at the schools and things like that. And so again, you know, that you're a grandparent with a cane, or if you're a parent with a young child in a stroller, as well as one who wants to run around the playground, it has made it so that they can get up and walk around and, you know, the circle and get a little exercise themselves without just having to sit on a bench and watch their kids. And so I think that these are the kinds of ways that you can, you know, make exercise easier and more accessible in a lot of different situations. I used to serve on the board of a domestic violence shelter, and, you know, we ran a lot of different kinds of groups during the week, but I'm sorry to say, you know, and I wish I had known, you know, then what I know now, that we did not have any kind of exercise routine incorporated into our weekly schedule, when it would have been so easy to, you know, offer like some simple yoga stretches, or even just, you know, taking walks or starting a garden in the backyard. I mean, there's all kinds of things that we could have done. And I think there are so many residential facilities that could do more for that, that would help so much with people's depression and anxiety. You know, and certainly, you know, that can be incorporated into other programs too, like day camps, et cetera, or part of the training for foster parents. And then finally, you know, even more simply than any of those, I mean, and one thing that I did used to do sometimes when I was still seeing clients is just, you know, make your session into a walking session and get a little fresh air and exercise. We know from the research on forest bathing that just being out in natural environments, which could just be a park or, you know, a garden, you know, is really good for people's psychological well-being too. And then I think I will say that if you were in a setting that you do need to provide for whatever reasons for to meet your regulatory obligations, or be able to bill for insurance, or whatever kinds of institutional demands are that you need to provide something that's like a more traditional psychotherapy, then I would really strongly encourage you to think about what it would take to shift your clinic or your institution or whatever it is to one of the more mindfulness-based therapies. So either acceptance and commitment therapy or mindfulness-based stress reduction. You know, I probably would put something like that at the top, or at least like DBT or something like that. You know, I think there's more and more evidence that those are the most powerful forms of therapy to offer because of the integration of mindfulness into them. And then I just want to say thank you again. And then we've tried to leave a whole bunch of time for questions. Before we turn to that, I will make a plug for joining my listserv if you're interested in keeping up with our work and news about resilience and victimization and related topics in general. You can join our listserv for free. I'll put the directions in the chat in a couple minutes so you can just copy and paste out of these. But I will stop there, and then I think we're just going to shift to Q&A.
All right. Well, yes, thank you, Dr. Hamby. That was wonderful. And I just encourage everyone to ask your questions in the Q&A now, and probably throughout we can keep asking more questions, but we already have a few. So one of the ones we got was, so it looks like, it says, what do you make of the jump at the 11 to 12 range on trauma dose? This was on the 8th slide. And then, because it was more linear until then, is what it asked.
Yeah, I'll pull that back up real quick so folks can look at it. I actually don't make a lot of that jump. As I said, this is real data and not, you know, like idealized data. I think that it probably is more linear progression. And some of our other we haven't found like really consistent evidence. I will say that, point out again that in Felitti and other people's work on adverse childhood experiences, that sometimes they found a jump at 4 or more. But I suspect that if you really did a meta-analysis on dose that over cross studies, that most of those jumps would probably even out, and that it would be a pretty linear dose response relationship where the difference between 10 and 11 is not any different than the difference between 7 and 8 or 8 or 9.
Okay, great, thank you. How do you factor in an individual's racial trauma from early years to present?
Yeah, that's a great question. I do think that racial trauma really adds substantially to somebody's allostatic load, to their total lifetime burden of trauma, whether it happens in the form of, intermittent microaggressions, or whether they are the victim of what some people call like a hate crime, assault, or something like that. And I think that the early work on, adverse childhood experiences questionnaires don't include racial trauma of any kind at all. The JVQ has one question on bias motivated victimization, but I don't think that was really a substantial enough focus on it. We did, with Lisa Jones was the lead on this project, we did a study a few years ago where we tried to expand the measures of different kinds of bias motivated victimization. And, we found in that, there was also a study of young people aged 12 to 21, I think, and that more than half of them had experienced some kind of bias motivated victimization, because that if you include, based on gender, based on sexual orientation, there's, because and I think it's important to realize too that you can be a victim of bias or hate crimes or microaggressions even if you're not actually a member of the group. So you might get somebody might use a homophobic slur against you when you don't identify as gay or queer, and so I do think it is a much more widespread problem than we had currently realized. But I do think that one of the reasons that we do need to really incorporate that into our measures of trauma dose much more systematically than we have been. But at the same time, I think that a lot of the things that help people overcome other types of trauma will help people overcome racial trauma. And of course, one of the things I saw that thing, there's something on volunteering, but I do think that to go back to the meaning making issue, that activism and community involvement, again, that's how I overcame a lot of my trauma. I think that is probably a lot of what motivates a lot of the folks that are on the webinar today. And that I think another thing that we can really do to help with racial trauma is make that a more central part of what we're offering to clients who are seeking help from us too, is to help them get involved with social justice activities, or volunteering for socially justice oriented organizations, or even, doing what we do and get trained to have some kind of professional role in those efforts. And, that is something that really needs to be brought more to the fore. There's a little bit of research on that. There's not, but I think that's another frontier where there needs to be a lot more work done.
Great, thank you. I wanted to just piggyback off that question. This one's more of my own. What has there been about, has that been a thought to incorporate, incorporate that in the ACEs or those evaluations in recent years?
Well, there are some revised versions of the ACEs questionnaire coming up. The thing about the ACEs questionnaire is that, it did build it did a good job of building on what sort of the current state of knowledge was in 1998, which for the most part was pretty, mainstream culture, white centric sort of stuff. And, but they didn't do like any kind of formal head-to-head comparisons there either about like what were the best adversities. And so if you really get into like the nitty-gritty of it, I mean, I think there's pretty widespread consensus now that some of the items that were included, that are included in a lot of common ACEs measures, are probably not, like if you're only going to ask 10 questions, like you're wasting real estate by asking some of them. So for example, there's a question on having an incarcerated parent, which frankly, I think is kind of a racist question because, I mean, obviously that is a traumatic loss, and so but I think that it's wrong to think that that's a more traumatic loss than other. I mean, like, what about the death of a parent? Like, the death of a parent is not on the Aces questionnaire, but having a parent, incarcerated is. And so there are a lot of, you really get into those kind of nitty gritty things. Another item that's on there that I think shouldn't be on there is divorce, which I recognize is, obviously like very stressful, but sometimes divorce is a response to these other traumatic, adversities. And so maybe it's a response to the domestic violence in the house or the addiction in the household. And so I don't, it might be a solution as much as it is like another adversity. And so I think that that's like a kind of a complicated item. And then meanwhile, there's not anything on peer violence, there's not anything on community violence. And so I think that people are shifting away. The World Health Organization has a revised version of the Aces questionnaire, which I think has got, a better spread of items on it. And we've worked on one too, but ours also does not really do a good job of incorporating racial trauma. And so I think that is really for like the next generation of indices.
Great, thank you. Here's another one. This is from Debbie Davis. She says, how important is connection for resilience? It seems that people are so isolated and divided. Could this be the result of trauma or collective trauma?
Well, I think it can be both. I mean, that is, I really think that a lot of the path to healing, if you're talking about, some of the political divides, that healing from trauma is going to be a necessary part of the solution to some of those problems. I think that, a lot of some of what's happening with some of the political divides we're facing now could be really seen in terms of like sort of classic externalizing after traumatic adversities. And I think a lot of those adversities are collective ones. And, there's more and more work happening on community resilience. And so, if you're talking about like losses of, like industries that were the major economic supports in regions, or the sort of collective trauma of underfunded schools. And, there's a lot of systemic injustices that are kind of needlessly adding to people's trauma burdens in so many situations. I do think that connection is important to resilience, but one way that we often define meaning making or a sense of purpose is connecting to something larger than yourself. And so I would say that that's the most important type of connection. And a lot of that, of course, does involve interpersonal relationships. So, to go back to, like Etione and I, we were just chatting before, you're like trying to remember, like, well, when did we, how did we know each other? And what year was that? We were, at the FRL, and, and so, I'm here, as I said, because I'm, my own sense of purpose is to try to do what I can to help reduce the burden of trauma, in society and around the world. But a lot of the ways that I enact that on a day-to-day basis is through connection and through relationships. And, Etione and I have known each other for, over 25 years, because we're just getting so old, Etione. And so I think that you can't take a mission like that and expect to, sort of cowboy it and do it alone. And so it, it is important to do it through those relationships and through, mattering, and feeling like you matter to others.
Great. Thank you.
Thank you, Sherry. This is exciting. Great to hear your wisdom. I want to invite you to comment on something that you mentioned in your book that you didn't really necessarily spoke directly, but it has implications for the whole talk, which is the relationship between attitudes and behaviors. And because I think it has practical implications as well as theoretical implications for doing prevention work, for fostering resilience. I wonder if you can tell people more about your view about that.
Sure. Yeah, I would be happy to do that. Thanks so much for that question, Etione. Well, so I think in terms of, I've mostly been talking about intervention here, but I think that a lot of these same principles apply to prevention. And so in my new book with Vicki Banyard, we have basically just taken the resilience portfolio and renamed it the prevention portfolio, because I think so many of the same strengths and resources help insulate people from violence as well as overcome it. And one of the main messages in the book that Etione is referring to is that I really am hoping that people are going to start letting go of what we call admonishment programs. I mean, that's the sort of like just say no to drugs kind of stuff, or this is your brain on drugs. You guys remember that old commercial where they would like crack an egg and put it into a frying pan? And but a lot of prevention programs as they currently exist, still kind of fall into that general, and what I always tell people is that, that lack of knowledge is not really the problem that behind very much perpetration. I mean, college males are not committing sexual assault because as an 18-year-old college student, they're not aware of the fact that, that you're not supposed to rape, right? I mean, it is not lack of information that people like me and people like all of you all are opposed to sexual assault, and that their mother doesn't want them to become a rapist, or, or things like that. And so just these psychoeducational models that are assuming that there's, that what they need is education about that. And like, oh, well, just in case you haven't heard, by, the year 18, in our culture, we're against sexual assault. What we need are programs that help people with, dealing with these kinds of challenges. And so the point Etione was talking about is that there's actually a large body of research in social psychology that shows that attitudes and behaviors are not that closely linked. And so even if there was some group of people out there who who are sort of consciously thinking to themselves, well, I don't see why you shouldn't be able to sexual assault whoever you want, and that changing that attitude is not necessarily going to improve their behavior. And you can see this in a lot of the prevention work that's been done, is that, there are lots of studies on violence prevention or substance abuse prevention where you can kind of shift their responses on self-report questionnaires about knowledge or attitudes about violence or alcoholism or whatever, but they doesn't change their behavior. And then you can also even see it the other way around, that like changing their behavior doesn't necessarily require changing their attitudes. So, I mean, I think that like there's a famous study on that. And I think this goes back to the point about being divided too, is that, that so many people are willing to express a lot more hostility and anger in like hypothetical situations than they are in real life. And one of the first studies that this happened a long time ago, like back in the 30s, this guy, Richard LaPierre, he asked a whole bunch of people, hoteliers, who, desk receptionists and what have you in hotels, whether they would serve an Asian American couple, and over 90% of them said no. This was back when it was legal to, engage in that kind of discrimination in the United States. But then what he would do is he would go to the same hotel and show up with an Asian American couple. And what happened is that over 90% of them served the couple anyway. And he said that actually the majority of them did it with what he considered like more than usual consideration. More recently, you can see this in like the Army with the anti-LGBT sentiments. So when they made it, they stopped discharging people who were identified as being LGBTQ plus people. More than 1,000 high-ranking officers in the military signed this letter saying that this was going to be a disaster for the military, and it was just, and that they were going to quit if they did it. And then, what had happened, of course, is that it was not a disaster for the military. And not only that, but like none of them quit. So, a lot of times, like even what people tell you are their attitudes doesn't really link to their behavior, and not necessarily for noble reasons. I mean, I think Liz Miller, the creator of Coaching Boys into Men, came and did a guest lecture on my class a few weeks ago. And she was talking about one of the first times that she did Coaching Boys into Men, which is a dating and sexual violence prevention program for like high school and college males. And she said she was talking to her husband about it at the end, and that she was really frustrated because she got the coaches to give the messages and, and change the rules so that they weren't tolerant of, of like all the, sexist and homophobic slurs in like locker rooms and practices and stuff like that. And then they were able to, show that there was a reduction both in like minor kinds of verbal sexual regression, but also in like sexual perpetration. And so, she had a good result, but she was really frustrated because she felt like she still hadn't really changed attitudes, especially of the coaches who were delivering it. And her husband was like, what did you think they were going to do? All become feminist? And she was like, yeah, I thought they were all going to become feminist. And I can totally sympathize with that feeling, because that's kind of the way that I feel about a lot, but the fact of the matter is that it's probably not that likely that some like 30 or 40 something year old coach, is not familiar with the principles of feminism. And then if they're not a feminist, it's not because nobody ever explained feminism to them before. It's because they've got, deep-seated feelings about male supremacy or whatever. And, and so, but we don't necessarily have to change those people all into feminist in order to help them not be offenders. I mean, that's actually like a pretty big gulf between those two things. And I think that, one of the things that we really have to do with prevention is stop thinking that the pathway to prevention is to get all of these people to become social justice warriors like we all are. And that, a lot of people are never going to become social justice warriors, but that doesn't mean that we can't, stop them from becoming offenders of different kinds, or even, self-destructive, addicts or whatever it is. And, and so we think that really the key to that, and that there's a lot of promising work happening in the prevention field as well as in the resilience field of thinking about other ways of doing that. So for example, the whole idea of nudges, which are kind of changing the social environment in a way that makes it harder for people to offend. That can mean surveillance cameras. I mean, it can be what could be the coaches. I mean, that the Liz Miller's coaching program is a good example of that, is that they were just going to get benched if they got caught engaging in any of these behaviors. And so, maybe that's not like the highest, most noble motivation. Instead, like I would like them to like say that they're not going to engage in these behaviors because they're going to stop, like hating women or whatever. But I'm happy if they at least just stop engaging in these behaviors. And if they're doing it because they don't want to get benched, that's better than having them do it, and so I think that we have to think about both social and physical environmental changes that we can make that will shift the environment to support the behaviors or the refraining from behaviors that we want to see, and that the way to do a lot of that stuff is going to be strengths-based approaches too. A lot of them are, there's this great, I think it's in some Scandinavian country, and now I can't remember which. Oh, it was Iceland. Like this alcohol prevention one, where they just started having these parents walking the neighborhoods at nights on like Friday and Saturday, and there's been quite a number of prevention studies that, for example, to go back to the social ecology, that show that they only work if they get the parents involved, and that if they help think about how they're going to limit alcohol access in the house and make sure their kids are not having parties, or or reinforcing like not driving drunk messages, and so it's not just going to be, another thing I think we really have to shift off of in prevention is just thinking it's going to be all about willpower, and then we need to think about environmentally, like how can we support the behaviors that we want to see. Which, I'm sorry, that was kind of a long answer to your question. That's my book in like 2 3 minutes.
That was a beautiful answer, and that was really, really informative and helpful. So I had a request from Charlotte Smiley, wanted to ask, make a comment out loud. So I'm going to unmute her for a moment.
Great.
I really liked what you presented as interventions and not just diagnosing the problem. Sometimes other groups just spend all their time talking about what the problem is. I've worked with a lot of teenagers over the years who've had major family trauma. But personally, I have a son who had to have an amputation for bone cancer, his leg amputated when he was 15. And I was thinking about how so many of the things that you presented were in his life. He is now in his 50s and a successful attorney and gives back to the community in other ways. And I was thinking one thing that wasn't there is the things that you get from involving a child in Scouts, either Boy or Girl Scouts. I made a list. It teaches values. You have nature and exercise, friendships, goals, and group belonging. I think a lot of these kids who don't have good family and friendships join gangs because they want that group belonging. And the Scouts provides that, although I know that they've had a lot of problems with sexual abuse, but they've taken a lot of steps since that time to prevent that, like encouraging or requiring parental involvement and things like that. So I just think that from my personal experience, that provided a lot of the things that I couldn't provide to make my son a very successful person.
Yeah, thank you, Charlotte. Thank you so much for sharing your story. And I'm so glad to hear that your son did so well after such a major illness. Yeah, I love the Scouts. I was a Girl Scout when I was younger myself, and you're right, it provided me a lot of things that I was not getting at home, and I was also a Scout leader when my daughter was younger, and in fact, even in the prevention book that we've been talking about, I mentioned Girl Scouts as one of the most positive community experiences that I've had, and I think a great model for what a more strengths-based approach to prevention could look like, because you're right, it does include so many of those elements when it is well done. And I think you're right. I mean, obviously in the Boy Scouts particularly, there has been this history of not being having enough oversight regarding the risk of sexual abuse, but I think they are making a lot of changes along those lines. And I also think integrating it with you know, the Girl Scouts aren't very happy about it, but I still think when it becomes gender integrated, that will probably go a long way towards making it a safer environment too. But I think Scouts is a terrific example of, you know, or any kind of youth group there, you know, are places that can really be hugely beneficial. And the great thing about the Scouting model, or most of the youth group models, is that they do what we were talking about earlier, and not just you know, give things or provide, you know, oversight or monitoring in the afternoon or on outings or whatever, but that they really also really support the development of kids' agencies and let them feel accomplished. And they have so many different ways of acknowledging when they've mastered new skills and things like that. And I just think that they are really very nicely designed to support you know, children's development. So yeah, I'm a huge fan for Scouts. Thank you for bringing that up.
Can you speak more on the stress response system, how it negatively affects youth, and if some areas of acting out are a response?
Sure. So, you know, basically we just, and, you know, there's the stress response system. I mean, it's not that the stress response system that we have for dealing with getting, you know, assaulted by or bullied at school or something like that is really not that different than the same one that we have if we're getting like chased by a bear. I mean, that's basically where it comes from. You know, it's just this very, you know, primitive sort of survival system. Our body is going to get flooded with cortisol and adrenaline, and, you know, and then, you know, and those kinds of things, they take a toll on you. I don't know if you've ever had, you know, an experience, you know, where you've really had, you know, just how, if you've ever had an experience where you've really been in a crisis situation where you're getting chased by a bear or whatever it is, you know, or maybe you've been in a car accident or something like that, you might know like how exhausting that is, and how you'll have this crash a few hours later, you might get a headache, you know, that those kind of, so that's what I mean by the, you know, the effects of long-term chronic stress on the system, is that our bodies aren't really built to, you know, that system is not really designed to deal with, like, you know, day in, day out emotional abuse, or being, you know, unsafe in your home, and being unsafe in your school, and being unsafe in your neighborhood. And I think probably the real reason that these dose things make such a difference is that there's no safe haven, that there's no place where you can really kind of decompress and unwind. And that is why it doesn't necessarily make that much difference, you know, what kinds of victimization or trauma you're being exposed to. You know, I mean, you might even just feel like if you've ever gotten, you know, heard about bad news for yourself or from a friend. I mean, you might even be familiar with just that kind of feeling of like it just sort of washes over you, and that's just like all these chemicals getting released. And, or, you know, I'm sure, you know, many of you have dealt with, you know, insomnia or other kinds of things. I mean, there's just lots of different ways that the body responds to stress. But, you know, we don't have like a special kind of insomnia, like if we're worried about our kids versus like, you know, whether we're having problems at work, right? I mean, it's just, you know, the things that are racing through your mind might be different in terms of the content, but the mind racing and the sleeplessness or the, you know, inflammatory responses, those are going to all be the same. And so that's why we end up with this dose response effect. Acting out, you know, I mean, I think that I would just kind of put that in the general category of like self-medicating, and that there are things that we do that sometimes are, you know, I mean, I guess the other thing I, you know, was going to say earlier about the difference between attitudes and behaviors is that one of the things that we talk about in the book is that, you know, is that I'm someone that I like to think I have like pretty virtuous attitudes, but I don't, you know, follow up to all of my attitudes, and, you know, in a lot of situations. So, you know, like we have talked sometimes about the Thanksgiving table in several places, and, you know, so I'm against overeating, and I think I should, you know, follow a healthy diet. But there are lots of times when I, you know, I'm not 100% perfect at that. Like pretty much almost every Thanksgiving, I eat more than I should. And, you know, and there are other times when I'm tired or stressed out, where I, might reach for junk food, or, or if I, or late and I haven't got time to do dinner, we might end up with like fast food or something like that. And, and so my attitude is that I should eat healthy 100% of the time. But the reality of it is that, I don't manage that 100% of the time. And, honestly, in a good month, if I'm hitting like 95% of the time, like that's a pretty good month for me. And, and so I think that that's kind of the same thing about self-medication and acting out and stuff like that, is that those are the times like regulatory challenges. And Kahneman, the cognitive psychologist who won the Nobel Prize, I mean, he talks about like the slow brain and the fast brain, or like hot moment, or slow brain or like cool moments, and fast brain are like hot moments. And so what happens is that that a lot of our intervention and prevention is offered in these like cool moments where we're all sitting around classrooms, or we're sitting in a therapy office or something like that, and we're having these really rational conversations. And if you gave me a questionnaire now about whether I should eat junk food, I'd be like, oh no, I should not eat junk food. And but the thing is that that's not when bad things happen, right? I mean, bad things happen when we get in these moments where we're dealing with rejection or insecurity or shame or humiliation. And the problem that with trauma dose and the way that it can affect your stress response is that it can make it even harder to self-regulate under those kinds of moments. And that is when, the acting out is just kind of a symptom of those sort of regulatory challenges. And when we make choices that we know are going to be bad for us and bad for other people in the long run, but we just can't manage in those hot, fast brain moments to make the same kind of choices that we know we should be making. And that's where a lot of like substance abuse and stuff like that happens too. Or going back to the issue of sexual assault, I think a lot of young men are just in a panic about their masculinity, and and being afraid of being a virgin when their peers aren't virgins, or maybe their peers are bragging about all these sexual conquests that may or may not be true. And and it's because of those those hot moment kind of feelings of like panic and insecurity and the effects of toxic masculinity and stuff like that, that are leading them to, take advantage of someone who, at a party or something like that, even when they know it's wrong and they might think it's wrong themselves and they don't want to think that they're a rapist or whatever. And so, for both intervention and prevention, we have to realize more that that nobody kind of plans on getting in a crisis. And so we have to think about like, well, what can we do to minimize those crises and minimize the self-destructive and other destructive choices that are available in the environment when crises do occur, because we're probably not going to be able to totally eliminate psychological crises.
This one is from Alfred Ramirez. He asked, do you see cross-discipline, social sciences, et cetera, used for your theories and practices?
Sure. I mean, that is another silo that we are trying to bust, so in the prevention book, for example, we make use of work in all different subdisciplines of psychology, social, developmental, positive, clinical. We also bring in a lot of work from social work, counseling, psychology, sociology, criminology. We even have stuff from critical race theory. We even have stuff from like urban studies and things like that, because I actually think that really bringing in more considerations of the physical environment is an area that I'm particularly interested in. Oh, my other student who's on the day, that's what she's working on, is trying to incorporate work on eco connections and sense of place into the strengths portfolios.
Yeah, it was making me think of what you had said earlier about just having a pathway in a park to walk, like it's urban planning and all that.
Exactly.
Yeah.
Oh, so, okay. Well, yes, Etienne.
Yes, and question for you that you mentioned and directly that we as a field are underdeveloped in the our own training on issues of trauma and the and resilience for the clinicians that we're preparing. Yet, if the data is correct, then we are well versed on our own experiences on those, you know. And so I wonder what your thoughts are then in going against the grain of what most of us who were trained a number of years ago were trained not to do, which was like, do not really use your experience in life and your own traumas to really dictate or inform the way that you're practicing with the stress that others are suffering.
Yeah, I mean, that is a great question. I mean, I think that there is certainly, I mean, there's such a, I mean, the problem is that there's this middle path to walk, and it's very easy to stray off of it one direction or the other. So historically, we, I think, have been over concerned with straying in the direction of like over disclosure or projecting our problems onto somebody else, or, you know, and certainly that can be a problem. I mean, I've talked to so many people over the years who are like, well, I tried to go get couples therapy and all this woman did was talk about her own divorce. And I mean, I'm sure you've all heard stories about that. And so obviously that is hugely problematic. And, you know, I think that what we have to, and I had a student many years ago who had lost her, whose family experienced a domestic violence homicide where her father had shot and killed her mother, and her father was now in prison. And she had really, you know, done a great job, you know, overcoming like obviously a really horrific trauma. You know, she was well on her way to graduating from, she graduated from college, and you know, and she was doing a lot of community work, like going and telling her story and trying to get more attention to, I mean, I think domestic violence underlies so many of our, you know, even like mass shootings and other problems like that. And she's talked about wanting to become a therapist, but it turned out that, you know, she was basically just her idea of like doing therapy was just that she was going to tell all these people her story. And I was like, well, you know, I mean, and so the trick about that, of course, is that what worked for her or for me or for you or for anybody else, I mean, that's not going to necessarily work for everybody else. I mean, not everybody, you know, is going to become a therapist. I mean, that's not going to be, you know, even to take the most basic thing is to become their solution. And so I think there's a real struggle about it, and something that needs to be emphasized in training about how you can, you know, you have to find this way of like learning to be able to, I mean, it's just like with the post-traumatic growth, right? To be able to acknowledge what your own experiences were, to learn from them, but not to think that everybody is going to be like you, or that the solution that worked for you is going to work for everybody. I mean, you know, you see those kind of problems. I mean, maybe like the biggest place that you see that problem is in AA, which I am a huge fan of AA. But some people are like, well, you know, the only way to recover from alcoholism is to go through AA, and that's just simply not true. I mean, that solution is not going to work for everybody, you know, and so there has to be that balance. And I do get that it's super easy for people. I mean, of course, the biggest problem with personal disclosures is that people are trying to get their own needs met when they're supposed to be helping somebody else. And, you know, we do have to make sure that we're not using the time that we're supposed to be providing services to others to try to get our own like psychological or social support needs met. So you do have to kind of work through all of that stuff in a way that, frankly, a lot of training programs no longer really provide good space for. But at the same time, you know, if you go off into this other direction of like pretending that we all are like perfect and that we never overeat, or that we never, you know, like blow off exercising, or that, you know, or anything, you know, or that we never, you know, have one drink too many when we go to a wedding or something like that. I mean, we can't, all of that kind of pretending, you know, I mean, that's actually one of the things I talk a lot about in my TED Talk, which I would invite you all to check out too. If you just Google my name and TEDx, it should come up. And is that kind of pretending has real cost, because it makes it look like we're somehow up on this pedestal of like these perfect people who don't have any problems. Charlotte, I really appreciated you sharing your personal experience with us, because even though I know that like my solutions aren't going to be the solutions for every single solitary other person. I mean, at least being able to be more of a real human being for our clients, I think is so important. And I think that it does mean that we miss a lot of opportunities to help, that we miss a lot of opportunities to share. And then especially it's one of the reasons that I think that we don't ever suggest that people, like, oh, and you might have a client like, oh, you should think about, maybe trying social work, or, or have you ever thought about like volunteering at Habitat for Humanity or things like that? And, or maybe you'd make a great Girl Scout leader. We don't do enough to try to help people see that they could take a path that's in the sort of general ballpark of our path, when we pretend that we're so different from them when we're not really.
So it looks like we do have time for one more question. So I wanted to pose this one from Charlie Delancey. Yes, for different races, we go through things and go through things differently. How important is it to understand different races when you're trying to help someone, but you've never been through the things that they deal with on a daily basis?
Sure. That is a great question, and obviously a very tough topic. I did spend in the 90s a couple of years living and working on the San Carlos Apache Reservation in Arizona. And, that was the first time that I had lived in a community that was majority non-white. And, I think you have to be careful to overgeneralize, not all white people are the same, or all Apache people are the same, or what, whatever, but there are certainly, I love the way that they think about this, and like some of Kate McLean's and some other work in more developmental psychology, is that they think about this in terms of narrative. And so, and that the different communities and cultures will have master narratives, and so the narrative is something that you will see. So for example, in the Apache community, like the nicest thing you could say about someone is that they're a strong person. And by that, they don't mean physically strong. They really mean emotional strength, and they mean the kind of person who sticks to their values when times are tough, and is loyal to people, through ups and downs. And, and that actually is a lot of where we got the inspiration for our psychological endurance scale. And so that's a good thing in like mainstream white culture too. It's not like it's not a bad thing, but it's not like the thing, and that's like we're such a prominent value as it is in Apache culture. And so I think you do have to, be culturally fluent in whatever community that you're trying to serve, and that not everybody in that community is necessarily going to think about being strong, for example, in the same way, or maybe some of them might even reject that as an important value. In that literature on master narratives, they would call that like alternative narratives. And so I think it's helpful because it doesn't stereotype people and say that they're always going to be the same, but you probably have to reckon with that narrative, even if you don't want to identify with it. And then you can have like your own personal narrative. So for example, for me, I live in the Bible Belt, and I spent, and I'm a pretty secular person myself. And so, I don't really identify with that master narrative, but I'm fluent in it, and I understand how to relate to people around it. And actually, like, we didn't talk about that today, but I do think that that trying to be overly secular, even though I understand why most social services and healthcare services are secular, and I understand that that everybody should be able to go there and feel like they are getting helped. I think it's also important, it's another one of those mistakes that we make at Tioni, that we've gone too far over there to like only talking about secular stuff, when, religion and faith is so important to so many people. I love to tell this story about this one woman we were interviewing a couple of years ago, and we were collecting interviews at a children's advocacy center, and she had a therapy appointment right after her interview with us. And she came in wearing this big oversized t-shirt. It went like all the way down to her knees. And in like probably one of these like big, 18-inch letters, it just said Jesus. And, and we were trying to figure out the role of spirituality is one of the things we're working on our resilience portfolio work. And so when we got to that section of the interview, I was like, well, I'm guessing by your shirt that you're like a pretty religious person. And, it's like a little bit of a hint, right? That you're like walking around like this big, sandwich board for Jesus. And, and then she, of course she was, and she talked about that. And then it turned out that she had recently left her church, and many of you probably know this, but for people who are really religious, that is just like a huge life event. I mean, that can be like a divorce or something. And she was talking about how she'd had some falling out with the people and the choir, I think it was, at her other church. And so she'd left and moved to this other one. And her son, who was the CEC focus, had lost a lot of his friends. And I said, well, and how's that, dealing with that in terms of your therapy? And they're like, oh, well, it hasn't come up, and I'm like, what do you mean it hasn't come up? And she's like, well, he never asked me anything about my religion. And, and so I think that that's just like a really good example about how, like I get, why we generally take a secular approach. And as I said, I'm a pretty secular person myself, but I think it's also, sad that we are missing what is such a huge part of so many people's lives if we don't integrate that into our services. And, in that particular story had a happy ending because I contacted the guy and I said, they're actually going through all these things, and, with her permission, of course. And, and then they had a really great conversation about it. And he became aware of like this whole other thing that was going on in their lives that he would not, had not been bringing into the therapy. And, and a few weeks later, wrote me this really nice email about, like how helpful that had been to them. But I think that those kinds of things, those understanding what people, and you can't make an assumption like just because, somebody lives in the rural South that they're going to be super religious, right? I mean, you wouldn't want to ever assume that, but you should definitely understand like what the master narratives are in those communities and explore it with people, like how they see themselves in relationship to those master narratives. Sometimes it can be great. I mean, and when I work with domestic violence victims, if they are an active in a church congregation, it's like, wow, that is like such a huge bonus for someone trying to provide services, because those people will help them get furniture and they'll give them rides. And, some of the churches I work with will even do things like pay people's utility bills and stuff like that. And it just opens up like all of these resources that, are just so terrific for us. And so, so I do think that it is essential to have that kind of community fluency. It doesn't have to be race-based. I mean, just every community has its own culture, and to bring that into your assessment of what people's portfolios of assets and resources are.
Wonderful. Thank you. And thank you so much for today. And I think a lot of people have written in and been really impressed with your slides. And so I wanted to just ask if you would feel comfortable sharing those, or us sharing those with some of the people that have asked.
Sure, I'll send them to you and then you can pass them on to the attendees.
Perfect. Thank you so much. And so I want to, again, thank you. My heartfelt thanks for this. And we really have appreciated this. I know everyone who's attended has really appreciated it. And I just want to quickly turn it over to Dr. Alderondo. And
just briefly to say thank you to all of you. I hope that you stay safe and healthy. Thank you, Sherry, for spending the time with us, for sharing your knowledge with us. Remind the audience and the folks who are still with us that everything that the Institute does it does for free. And we rely heavily on your kindness and contribution, your donations to the Institute to continue bringing this type of state-of-the-art knowledge to you and to our communities. We're most grateful again, Sherry, for spending time with us and for having you as part of the Institute right now. So thank you very much.
Yeah, thank you, Ed Tioni. I'm so excited to be getting more involved with the Melissa Institute, and thank you for the invitation to be here today, and for everyone who has stuck through this session, and yeah, and donate to the Melissa Institute.